Welcome back to the Art of Cerclage. In this video, we'll be focusing on abdominal cerclage. The learning objectives for this video include reviewing the indication for abdominal cerclage, discussing important surgical planning and techniques, and showing a video of abdominal cerclage placement. A quick reminder of the 4 indications for cerclage. History, physical exam, and ultrasound indicated cerclages are placed via the vagina. In this video, we'll be focusing on cerclages that are placed in the abdominal cavity. This falls under the history of unsuccessful cerclage indication. Like previously mentioned in this series, history of unsuccessful cerclage is not standard medical terminology like the other indications, history, ultrasound, etc. However, it helps us understand the reasoning for placement of an abdominal cerclage. Abdominal cerclages are reserved for patients who've had a prior history indicated or ultrasound indicated vaginal cerclage, but then unfortunately had a second trimester loss, i.e. an unsuccessful prior vaginal cerclage. It's important to point out that this does not apply to physical exam indicated cerclage. For those patients in a subsequent pregnancy, they should be offered a history indicated vaginal cerclage. Abdominal cerclages are also indicated in patients who have anatomic limitations for vaginal cerclage placement, like a trachelectomy. You would be unsuccessful if you attempted to place a cerclage in a patient who does not have a cervix. Other examples of anatomic limitations include severe cervical scarring, or a patient with a history of a cervical cone who does not have adequate exposed tissue in the vagina. The 2 routes for cerclage placements are the vagina and abdomen. This picture helps illustrate the increased efficacy of an abdominal cerclage. Both McDonald and Sherrod-Carr techniques place the cerclage as anterior as possible on the exposed cervix in the vagina. Since the Sherrod-Carr method requires anterior dissection, often it's even more anterior than the McDonald cerclage and therefore closer to the internal os. The abdominal cerclage, since it's placed via the abdominal cavity, is placed at the level of the isthmus. The isthmus is the cervical uterine junction on the exterior, which is reflective of the internal os, the cervical opening of the uterus in the interior. This internal and anterior placement closer to the internal os decrease risk of caudal suture migration as the uterus enlarges, and the absence of a foreign body in the vagina that could promote infection and inflammation are possible reasons abdominal cerclages are more effective than vaginal ones. Let's discuss some more specifics about abdominal cerclages. Timing. Abdominal cerclages are typically placed prior to conception. Some surgeons will offer placement in the late first trimester or early second trimester. However, preconception placement is associated with more successful pregnancies and fewer serious surgical complications. Preconception placement does not affect fertility, but the data is limited. Delivery. Patients with an abdominal cerclage cannot labor, as there is an increased risk of uterine rupture. This necessitates cesarean deliveries for all pregnancies. An important note is that there isn't a consensus statement on when these patients should be scheduled for delivery. Some recommend 37 weeks, similar to a prior classical incision, while others recommend delivery at 39 weeks. Delivery timing is an important discussion between patient and provider. Removal. Unlike vaginal cerclages, which are removed during the same pregnancy, an abdominal cerclage remains in place for future pregnancies until childbearing is complete. If a cerclage is not removed at the last cesarean, it's unclear if an additional surgical procedure is needed to remove an asymptomatic cerclage. There are some reports that leaving a cerclage in situ can lead to infection and erosion of the cerclage into the vagina many years later, while other reports say that the risk of infection and erosion are very low, and that removal actually increases the risk of injury and complications. Again, removal is a discussion between patient and provider. Now you may ask, if we know abdominal cerclages are more effective, why don't we just offer abdominal cerclages for everyone? We must consider the risk and benefits of each type of cerclage. First of all, abdominal cerclages are much more morbid procedures, as laparotomy or laparoscopy is required for placement. Vaginal surgery in general is lower risk. Secondly, the nature of an abdominal cerclage precludes patients from having a vaginal delivery and necessitates the need for cesarean delivery in all pregnancies. And for those who have not had a prior vaginal cerclages can often be successful. There is one randomized trial that compared abdominal and vaginal cerclages in patients who had a history of a prior unsuccessful vaginal cerclage. Those with abdominal cerclage had significantly lower rate of preterm birth, less than 32 weeks, and had improved pregnancy outcomes. So for this particular population, the data supports an abdominal cerclage placement as it outweighs and justifies the overall higher morbidity. The surgical approach is another important consideration. Placement of cerclage can be via laparotomy, an open incision on the abdomen, usually Phanon-Steel, or laparoscopy, using a minimally invasive technique. Laparotomy can increase intra-abdominal adhesions and scar tissue, making subsequent cesarean deliveries potentially more difficult. They also require patients to stay inpatient for 1 or 2 days postoperatively. Laparoscopic placement of abdominal cerclage can be done via conventional straight stick or robotic assisted. It's less invasive, and patients generally can go home the same day of the procedure. However, it does require a skilled laparoscopic surgeon, which may not be available in all places. Both laparotomy and laparoscopy have over a 90% success rate, and intraoperative complications are similar between approaches. However, laparoscopy is the preferred approach if an experienced laparoscopic surgeon is available. Let's review some important points for the operation. In general, for this procedure, prophylactic antibiotics are not indicated for either laparoscopy or laparotomy, but the decision to administer them is up to the surgeon. The suture used in an abdominal cerclage is non-absorbable and permanent, as we do not want it to dissolve. Generally, Merceline tape is used because of the wider band and support. In laparotomy, supine positioning is used. Hands or gentle retraction with instruments helps with visualization and manipulation of the uterus. In laparoscopy, the patient is positioned in dorsal lithotomy. This is especially important for a robotic-assisted abdominal cerclage placement. Additionally, the placement of a uterine manipulator in a non-pregnant uterus is important to get adequate visualization and to help delineate the cervix. Just as in vaginal cerclage, the cerclage knot can be tied anteriorly near the bladder, or it can be tied posteriorly near the rectum. Either placement is fine, and it depends largely on surgeon preference. Many tie the knot posteriorly so not to accidentally cut the cerclage knot when performing a cesarean delivery. Now we are going to briefly discuss the major steps of abdominal cerclage placement. The steps, once in the abdomen, are the same whether performed via laparotomy or laparoscopically. Pictorially, we will show an abdominal approach. Note the bladder is anterior to the uterus, and the rectum and sigmoid colon lies posteriorly. First, a bladder flap is created to help expose the isthmus and protect the bladder from injury. Once the reflection is adequately exposed, important anatomy should be identified, including the uterine artery, both ascending and descending, and the ureter. Using a thumb and forefinger, draw laterally away from the uterus and expose the avascular space next to the isthmus. A needle with the Merceline tape can be driven through this avascular space. Or alternatively, a tunnel can be made in the avascular space and the posterior broad ligament, and a right angle with a preloaded Merceline suture can be passed through. This is a critical step, as you do not want to injure the uterine artery and cause significant bleeding. The same method is used to pass the Merceline on the other side through the avascular space. Be mindful of the suture ends so that the knot can be tied anteriorly or posteriorly, depending on the surgeon preference. Once the Merceline is wrapped around the uterine isthmus, ensure that it lies flat against the uterus and tie to compress the tissue. Secure with a square knot. The ends of the Merceline tape can be sutured down with non-absorbable sutures to prevent it from rubbing and causing irritation, pain, inflammation, or erosion. The peritoneum can also be reapproximated for additional protection. This completes the procedure. There is one additional consideration that is important to discuss, which is management of fetal demise or desired termination after abdominal cerclage placement. In the first trimester, a D&C can safely and effectively be performed without removal of the abdominal cerclage. For early second trimester, a D&E can usually be performed with a cerclage in situ. Reports have discussed adequate dilation up to 16 millimeters, and laminaria can be used to facilitate dilation. If late second trimester or third trimester demise, the cerclage needs to be removed laparoscopically prior to a D&E or an induction of labor. It is not recommended to perform a laparotomy and a hysterotomy to remove the fetus in order to leave the cerclage intact. Providers can always contact those with more family planning experience to assist. Now that we've reviewed the pertinent information of abdominal cerclage, we'll watch the placement of a cerclage in a robotic-assisted laparoscopic case. You can see the delineation from the uterine manipulator, which assists the surgeon in making a bladder flap. Here, a tunnel is made through the posterior broad to better isolate and skeletonize the uterine arteries. The surgeon carefully avoids the uterine artery while passing the needle through the isthmus. And then the surgeon proceeds to the other side. Notice how the surgeon is ensuring that the tape lays flat. The cerclage is tied tightly with square knots. Let's review what we've learned. Abdominal cerclages are an important tool for prevention of preterm birth in those with cervical insufficiency. Because of their increased morbidity, they are only indicated for patients who've had an unsuccessful prior vaginal cerclage or who have anatomic limitations. The cerclage can be placed via open or laparoscopic surgery. Minimally invasive route is preferred if an experienced surgeon is available. We hope this video is helpful. In our next video, we'll discuss the removal of a vaginally placed cerclage.